Hi there.
How are you going?
Not too bad.
Yep. I'm really interested in what you're talking about today. So,
Oh,
yeah.
I looked at the schedule and I thought, oof, this is a bit left field, but hopefully something different will be good too.
No, yeah, I'm really excited. Yep. Do you want to take it away?
Yep, I'll share my screen.
Thank you.
Sorry, let me try that again. There we go. Cool. Okay, does that look okay?
Yep, that should be fine.
Great, thanks. So hi everyone, and thank you for this opportunity to present here at 24 Hours of STEM. I'm Diana from the University of Sydney, and I graduated just a little over a year ago. I finished my PhD at Professor Jamie Trickus's lab, and he was a fantastic supervisor. As a fairly clumsy and absent-minded person by nature, I got into a lot of mishaps in the lab, but he was so lovely and patient. So definitely check out the Tricky Lab Twitter to see the amazing work being done in the lab. Because I'm still pretty new to the field of scientific research, I wanted to tell you a little bit about the path I took before I share what I'm doing now.
Sorry, excuse me.
Yeah.
Yep. So right now we're not seeing the whole slide screen. We're seeing.
Yeah, gotcha. Let me for you.
Yep, that looks better. Yep, thank you.
So I thought I'd tell you a little bit about the path I took before I talk to you what I'm doing now. And in high school, I graduated and I pretty much thought, okay, I'm going to study genetics. And that was what I planned to do. I was really excited by the elegance of DNA, and I thought it was super cool how everything in our bodies pretty much boiled down to only 4 bases. But what happened next was that I discovered a problem that kept bothering me. And if anyone is looking for their passion or their purpose in life and they're thinking, oh, there's nothing that I really love, I can highly recommend starting with something that bugs you instead, because it can definitely lead you places. It was in my second year of my degree, and I came across a problem that had been around for a long time, but was news to me. And it was a disease that was more than 5,000 years old, that still somehow killed over 4,500 people every day, pretty much in current times. And I thought, what? Why is nobody talking about this? And, tuberculosis is the name of the disease, and it's something that many people think have disappeared from the world. But over 3 billion people are infected right now as we speak. Evidence of tuberculosis has been found in Neolithic human remains and Egyptian mummies. It's believed that Pharaoh Akhenaten, as well as his queen Nefertiti, died of the disease. And in ancient Greece, Hippocrates, as well as Aristotle, wrote about the effects of tuberculosis. It was known as consumption, or the White Plague, in 18th and 19th century Europe. And today, these headlines are just a small sampling of the damage tuberculosis continues to wreak upon the modern world. And the burning question in my mind was, why? So I finished my degree, I left genetics behind, and I applied for a tuberculosis drug discovery project in Professor Jamie's lab for my honours year. Riding on the high of graduation, I thought to myself, okay, this is it. Time for me to have a crack at it. Tuberculosis is going down. And of course, I was hit with reality pretty soon afterwards. So this is the theory of the 4 stages of competence, which is a nice way of outlining how people develop various skills. And I'll tell you now that I went from here to here unbelievably quickly. There were many, many reasons why tuberculosis is still the top killer in the world today, and I really had no clue what I was facing up against. So now I spend all my time between these 2 stages, and one day may reach for the 4th stage of myth and legend. But nevertheless, I learned a huge amount in my postgraduate studies. And I got to meet and work with so many amazing people in the University of Sydney as well as Centenary Institute. So now I'm a researcher at the tuberculosis research program at Centenary Institute under the supervision of Professor Warwick Britton. And there's always room in our lab. So if anyone's interested in trying out a summer student program or enrolling in honors, just shoot me an email, just let me know, and we'll see what we can do for you. What I really want to do in this hour is tell you the inside story of drugs and how drugs and vaccines are discovered from the beginning to the end. The main drugs I'll cover in my talk are antibiotics because that was the focus of my research for the past 4 years. We're lucky enough today that we can walk into any pharmacy or chemist and see shelf upon shelf of medication purpose-made to cure whatever ails us. We can get a prescription for antibiotics when we're battling a tough infection or recovering from surgery. And while many people are probably not as happy to see a needle, both vaccines and antibiotics are critical advances in improving our quality of life. In fact, the US Librarian of Congress ranked vaccines as 5th in a list of top 10 inventions that changed the course of human history, featuring other groundbreaking advances such as the printing press, cars, phones, computers, and of course the quintessential light bulb. I think this figure really nicely illustrates the impact of the antibiotics on deaths from septicemia or blood poisoning. This is from 1910 to 1970, and the data is from Sweden and Finland. And you can see that once the antibiotic sulfanilamide is used on patients, death rates begin to drop pretty much immediately. And then when penicillin comes into the picture, you can see death rates drop down to almost 0. And some of you might be thinking, hang on, penicillin was the first antibiotic ever discovered. It's quite famous for that. And that's true. It was in 1928, I believe, but it wasn't widely used on patients for quite a while. And so that's why you can see the sulfanilamide data earlier here. This figure shows the effect of chickenpox vaccination on disease incidence in several states of the United States. And again, you can see the decrease in chickenpox cases in all of these states once the 1 dose and then second dose recommendation is implemented for vaccination. Of course, our huge advances in human health are not down to just antibiotics and vaccines. If we have a look at this figure, which shows the combined deaths from all infectious diseases between 1900 and 1996, we can see that implementing a public health system in the form of health departments for 40 of the states, as well as better sanitation and cleaner water, led to a huge reduction in mortality straight away. Everything works together. And if you think about human health, it's important to understand that it's an intersection of education, access to healthcare, public policy, research, and innovation. And this combination that we've reached is something that human history has been working towards for a very long time. So I guess the question is, how did we get to where we are today? And how did we learn to protect ourselves and combat disease effectively? It comes down to, I think, 2 core human instincts: looking at the world around us and asking questions about it. And anyone who spends a lot of time with young children will know for a fact that we were born with these drives. And the more that we nurture them, the more that we can enrich our existence. So I want to take you back all the way to the olden days, before all the important discoveries, and have a look at these questions from that viewpoint so that you can see how far we've come. So imagine we are this perplexed medieval fellow here. And what he observes is that people can become sick and die. And his question is, why? Why does this happen? On the way to answering that question, we do bump into several others. We have to ask ourselves, well, what do we know? What don't we know? What are the gaps in our knowledge? What can we do to resolve these gaps? And what tools and resources do we have at our disposal to help us start addressing these issues? Well, back then, our medieval fellow knew that sickness was suffering and suffering was caused by the devil. And that was the reigning ideology at the time. But they had their church, they had their healing saints, and their king had the healing touch as well, as they believed, so they hoped and they did their best. If we fast forward a bit, however, we can see that the question still stands without a real satisfactory answer. But observations about sickness were more specific now. People now knew that sickness was more common in places with poor hygiene and sanitation, where decomposing food or human waste could be found. So sickness was then believed to be caused by bad smells and bad air. And we know about this because of the posters back then, as well as the ways in which doctors were trying to protect themselves from their patients. We all know that during the Black Death epidemic, doctors wore these masks and they stuck perfume in the beaks in order to protect themselves from the miasmas or the bad smells. And we know that the wealthy people often traveled to the seaside to take in the clean air. Crowded cities tried to keep the streets a bit cleaner, and that no doubt had a positive impact on improving human health as well. And so as you can see, as we get more information, we come closer to a real answer to the question. Today, thanks to the work of John Snow, Louis Pasteur, and Robert Koch, we know that there are two kinds of diseases: infectious and non-infectious. You can't get a non-infectious disease such as cancer, diabetes, or asthma from another person. But infectious diseases are caused by tiny microscopic germs, which we can certainly catch and pass on to others. Well, how did they definitively prove that germs cause disease? Robert Koch wrote a series of rules known as Koch's postulates, and they governed the way you gained the proof for this kind of question and linked a germ or a particular microorganism to a disease. So in his studies, he wanted to prove that a certain bacteria caused anthrax. So what he had to do was first show that every time someone was sick with anthrax, you could find this germ in them. Secondly, he grew the germ in a pure culture and he characterized it, what it looked like, its morphology, what it looked like when it grew on plates and in liquid. And then he took that pure culture and he injected it into a healthy animal. And he showed that after this injection, the animal also fell sick with anthrax. But he wasn't done yet. To complete the links, what he had to do then was then recover that same organism from the sick animal, grow it again, and show that it was the same before and after. And that's how you can definitively link a certain germ with a certain disease. What are germs and how can we combat them? Most people are familiar with the more common types of germs, such as bacteria, which cause tuberculosis and meningitis and strep throat, for example. There are viruses, such as our current COVID-19 pandemic, as well as the common cold and flu. There's fungi, which causes ringworm and athlete's foot and thrush. There's protozoa, little microscopic animals that cause malaria and leishmania disease. There are worms, such as tapeworm or river blindness. And there are prions, which are the smallest of all, and these are responsible for mad cow disease and Creutzfeldt-Jakob disease as well. And the question is, which of these germs do we use antibiotics for? It's bacteria and bacteria only. So if you're ever suffering from a cold or a flu and you're thinking that you need some antibiotics, you do not. Bacterial diseases are the only thing that antibiotics will be effective against. There are many ways to protect ourselves from bacteria. High temperatures will kill bacteria, which is why we sterilize baby bottles with boiling water. Soap doesn't kill bacteria, but it helps wash it away from our skins to prevent our risk of infection. Alcohol is the most common active ingredient in hand sanitizer and will kill bacteria, along with chlorine in swimming pools, bleach, strong acids and bases as well. Our bodies and immune systems also protect us from bacteria. Our skin is a strong natural barrier, which is why we need to bandage our cuts to prevent infection because the cut has punctured through our skin and it's an opening through which germs can get through. Immune cells will constantly patrol our insides to find and kill any bacteria that manage to make it through our barriers. However, all of this is not foolproof and can fail. Many people have had a bout of food poisoning or a bad sore throat, and these are all due to bacteria bypassing our defenses and multiplying in our bodies. The environment inside us is very warm and very nutrient rich, so there are pretty much ideal conditions for bacteria to grow. So a lot of the time, our immune systems will be able to eventually bring infection under control, but this doesn't always happen. And then without some extra help, we can end up very sick and die. However, this is where antibiotics come into play because, as you can imagine, all of the things that kill bacteria are also not fantastic for us. There is no feasible way you can apply any of these to kill bacteria that are already inside your body without doing yourself harm as well. So one of the earliest antibiotic pioneers, Paul Ehrlich, theorized back in 1900s that it is possible to design a drug to target harmful microbes without hurting the rest of the body. He called this theoretical drug magische Kugel, which translates to a magic ball or a magic bullet, and antibiotics are still nicknamed that today. His lab was the one that actually discovered the first such magic bullet, salvarsan, but it's not often counted today as the first antibiotic because it was pretty toxic and a lot of patients actually died upon administration of salvarsan. What I want to draw your attention to here is this golden age of antibiotic discovery, where we discovered several new classes between 1940 and 1980. In contrast, there has been a desperate antibiotic drought in recent times, as you can see here. Most of what we use today and get from the pharmacist with our prescriptions are variations on the antibiotics discovered 60 or more years ago. And the search for more antibiotics becomes more and more urgent as antibiotic resistance continues to rise. So I'd like to show you all a very good 5-minute video that explains why we're in the middle of an antibiotic crisis and how antibiotic resistance occurs. So hopefully this will work. Okay. Oops. How do I go?
It's fascinating.
There we go. So I find that video a very accurate and succinct explanation of the problems facing antibiotic development today. You can see on this graph here that antibiotics and vaccines have the lowest net present value of production for pharmaceutical companies. They're almost a tenth of what a pharmaceutical company would receive for the production of a musculoskeletal drug, such as an arthritis medication, for example. What we have is a situation at present which makes it impossible for pharmaceutical companies to develop antibiotics and still survive. Antibiotics for tuberculosis are particularly troubling because tuberculosis affects some of the poorest regions of the world. Treatment currently involves a combination of up to 4 different antibiotics, and they have to be taken every day for at least 6 months. It's costly, and many sufferers cannot access medication for the length of time required to completely eradicate and cure the disease. Drug-resistant tuberculosis is a huge problem right now too, and there are very, very few antibiotics that can treat it without very negative side effects such as permanent deafness or psychosis. As such, there is a very urgent need to find new antibiotics to shorten and simplify tuberculosis treatment, despite the barriers that are in the way. This problem was my honours project, and I continued to work on it during my PhD as well. The first step to looking for a new antibiotic to TB was asking, where should I begin looking? You know, where do antibiotics come from? And as that video mentioned, antibiotics come largely from nature. In fact, almost all current FDA-approved drugs, not just antibiotics, are derived from bacteria, fungi, or plants, and all of the current antibiotics are derived from nature as well. Plants are very well studied, and soil bacteria and fungi have been under intense investigation since the 1960s. So I thought, what else could I try? where else in nature might antibiotics be found? Different ones, new ones to help us deal with this problem. And the answer was the ocean. An estimated 25% of all of Earth's biodiversity is comprised of marine species, and over 3 quintillion microorganisms live in the marine environment. That's 3 times 10 to the power of 30. And furthermore, these marine microorganisms are able to produce chemicals and metabolites that are completely distinct to what's made by terrestrial species. And all of this makes the ocean a very prime, untapped source of novel antibiotics. We teamed up with the Australian Institute of Marine Science and were able to access their collection of samples from the Great Barrier Reef for this project. The Marine Science Institute is located off the coast of Cairns in Queensland, and they maintain a huge bioresources library by scuba diving on the reef, bringing back and cataloguing samples. They also operate enormous bioreactor tanks for growing coral and other reef organisms, which is super cool. In the end, they sent me around 1,500 different marine extracts, all frozen in little vials. And these came from a whole array of soft-bodied organisms such as sea sponges, sea squirts, stingers, and worms. What I had to do next was decide on a series of tests to narrow down the 1,500 samples to the best possible candidates for a new antibiotic for tuberculosis. And you can probably guess what the first question is. Does the extract kill the bacteria that causes tuberculosis? And the second question is pretty obvious as well. Does the extract kill human cells? Because what we're looking for is an effective but safe antibiotic, not something that's broadly toxic and will kill everything inside. What I did was I used plates that allowed me to test 96 samples at a time to speed things up. And I grew the same amount of bacteria in every well of each plate and then added the same concentration of each different marine extract. So there was 1 marine extract per well. I left them to grow for 7 days. And the idea was that if the marine extract was active, the bacteria would not multiply to the extent that if it was inactive. So the wells containing active drugs would not have a lot of bacteria in them. So it's hard to quantify the amounts of bacteria in these wells because they are microscopic. So in order to do so quickly and easily, I used a color-changing chemical called resazurin. So when you add resazurin to each well of these 96 well plates, it changes from dark blue to hot pink if there are living cells in there. So if that's the case, if the bacteria are dead, it stays dark blue. So it's a very easy way to tell which extracts are active and which ones are not. This is one of my plates from the experiment, and you can see that there are a couple of active extracts dotted around here and a whole bunch more that didn't work. And in fact, that's what we found. We found that out of the 1,500 marine samples, which are all here represented by 1 dot each, and this is the bacterial survival, you can see that most of them stay at about 100%. So the marine extracts that we used did not manage to inhibit their growth at all. So what I did was I marked all of the samples that were able to reduce bacterial survival less than 50% as the interesting ones for further investigation. To test for toxicity, I did pretty much the same thing, but instead of growing bacteria in the wells of the 96 well plates, I grew human cells instead. And so if it was pink, that was good. It meant that the extract was non-toxic. But if everything turned out blue, then it's not fantastic. Whatever the extract is doing is also killing human cells as well. I checked 3 different types of human cells. I checked lung cells, immune cells, and kidney cells, and I made graphs of their survival. And if any extract reduced survival, for any of these cell lines, I discounted it from further investigation. The next important question for any drug discovery project is, how strong is the extract? How much do I need to use to kill the bacteria? And this is important because you don't want to be having to give patients bucket loads of medication every single day. So the more potent the extract, the better it is. In order to test this, I kept reducing the amount of marine extract I added to the bacteria by half, and then looked at what happened to bacterial survival. So you can see that some extracts stop working pretty much as soon as you reduce their concentration by half, but some of them keep working at very tiny concentrations. And that's what you want to see. These potent compounds here, you can quantify their potency using the minimum inhibitory concentration, which is the lowest concentration at which you can get a reduction in survival below 50%. And the lower the MIC is, the better your drug candidate, pretty much. The next question I looked at is one of the reasons why tuberculosis is so hard to treat. The bacteria that causes tuberculosis hides inside lung cells, which makes it very hard for antibiotics to reach them. So I wanted to see if any of the marine extracts could overcome this problem. To do that, I infected human lung cells with the tuberculosis bacteria, and then I added the marine extracts of interest, and I left them for 7 days. And at the end, I lysed the lung cells, which basically means just to pop them open to release the bacteria that's still inside them, and then I quantified the amount of bacteria. And so you can see the blue column here is your untreated lung cells, and they have a lot of bacteria in them because pretty much the bacteria were allowed to just go for it without any inhibitors added. I added high, medium, and low concentrations of the same extracts just to see if we got a response depending on how much extract we added. And you can see that at the higher concentrations, we get a good reduction in bacterial loads inside the lung cells. But as you reduce the concentration, as expected, the bacterial growth increases again. Question 5 is another reason why tuberculosis is hard to treat. Not only can the bacteria hide inside lung cells, but it can also hibernate like a bear in winter. It drops its metabolism down really low, and this makes it essentially bulletproof. We don't call it hibernation, but a state of latency. And in order to test whether my marine extracts would work against latent tuberculosis bacteria, what I had to do was to force the bacteria into a state of latency. And I did that by adding nitric oxide into the plates where they were growing. So once that was done and they were in that state, I added the marine extracts, I waited, and then counted to see the numbers of bacteria that were left after the treatment. So what you can see here is that over time, the numbers of bacteria don't change. They're not growing, and that's because they are latent. So that tells us that the nitric oxide is doing its job. And on this side, you can see the extracts that, even though they worked on normally growing tuberculosis bacteria, they've stopped working here. We don't see any reduction in the numbers of bacteria after treatment, after 7 days of treatment or 4 days of treatment. However, a couple of the extracts still managed to work. Okay, and you can see how they've reduced our loads of bacteria, and it's a bit of a drop in day 4, and then we get more of a drop in day 7, except for this particular compound, which caused a little kick up. So it seems to have lost efficacy over the course of the 7 days. Finally, I also looked at whether any of the marine extracts could kill drug-resistant bacteria, because that would be the real bonus here in terms of drug discovery. You know, shortening treatment is one thing, but combating drug-resistant tuberculosis is another huge priority in this field. So what we did was test them against clinical isolates of tuberculosis that we took from patients at Westmead Hospital. And this is a sample plate. This particular strain was resistant to isoniazid, one of the main TB drugs. And you can tell that it is because this column was treated with isoniazid, but as you can see, it comes out pink. So all the bacteria there are very happy, they're actively growing, and so the residuum turns pink. Here, on the other hand, are our marine extracts, and you can see that they've managed to kill this resistant strain. And this is great because what it tells us is that whatever we've got is something new. It's something different. It's not working the same way as the drugs that we already have, which is very promising. So this was an exciting result. So just to recap, I started with 1,500 marine extracts, And by the time I finished all the rounds of testing, can you guess how many I had left? It's like a series of hurdles. It's just the survival of the fittest kind of competition here as they get eliminated one by one. And the answer is I had one. I only had one sample left in the end that managed to make it through the whole gauntlet. It came from a sea sponge. It was a Tadania sea sponge extract. And I did a lot of work to purify the sea sponge extract because it was basically a crude mixture. What the Marine Institute had done was take the whole sponge and basically grind it and render it down into a powder. And I used that powder to basically test against all of these different screens. So it contains thousands of different components, and we weren't sure which one was the active one. So we did a lot of purification using HPLC, and then we did the identification process using NMR, and I ended up with the chemical that was responsible for the antibiotic activity. I then had to repeat all the experiments that I just showed you with this pure compound just to confirm that the activity remained the same. And the crazy thing is that all of these experiments were only the very beginning of the antibiotic drug discovery journey. What I did was just the preclinical stage. And then after that, new drugs must go through 4 different phases of clinical trials in larger and larger groups of people to prove that they're safe and that they work. It has been estimated that the time, the effort, the resources, and the funding that go into the development of a new drug is $2.6 billion US. The cost of human clinical trials alone is $19 million US. The time it takes normally from the beginning of discovery to FDA approval is around 12 years on average, but it can take up to 20 years. And FDA approval is not guaranteed either because the most recent statistics show us that FDA approval rates are currently less than 12%. So it's perhaps no wonder that many pharmaceutical companies are giving up altogether. Archaeogen, which was the company mentioned in the video that I showed you, did very well, and they managed to develop a new antibiotic for a drug-resistant strain of bacteria that was causing major problems in hospitals. And in their first year after they launched it, they made barely $1 million in profit. So if you can imagine that if they're putting out this much time and this much money, they had no choice but to be declared bankrupt in the end. So we have an environment that really does, in a sense, punish antibiotic discovery. But anyway, hopefully things will get better. And having taken you through the drug discovery process, I'm going to switch over to the vaccine side of things now. Vaccines work very differently to antibiotics. So we know that antibiotics kill bacteria which have infected our bodies, but what vaccines do is prevent us from becoming infected in the first place. And as the old proverb goes, an ounce of prevention is worth a pound of cure. Immunity is an invaluable weapon for combating infectious diseases, and we can clearly see that with regards to the current COVID-19 situation, where 120 labs around the world are frantically working to develop an effective vaccine to halt the spread of disease, get the world moving again, and pretty much let us get our lives back on track. As an introduction to the topic of vaccines, I'd like to show you this 4-minute video on the eradication of smallpox, a deadly and disfiguring disease that no longer exists today.
"10,000 years ago, a deadly virus arose in northeastern Africa. The virus spread through the air, attacking the skin cells, bone marrow, spleen, and lymph nodes of its victims. The unlucky infected developed fevers, vomiting, and rashes. 30% of infected people died during the second week of infection. Survivors bore scars and scabs for the rest of their lives. Smallpox had arrived. In 1350 BC, the first smallpox epidemics hit during the Egypt-Hittite War. Egyptian prisoners spread smallpox to the Hittites, which killed their king and devastated his civilization. Insidiously, smallpox made its way around the world via Egyptian merchants, then through the Arab world with the Crusades, and all the way to the Americas, with the Spanish and Portuguese conquests. Since then, it has killed billions of people, with an estimated 300 to 500 million people killed in the 20th century alone. But smallpox is not unbeatable. In fact, the fall of smallpox started long before modern medicine. It began all the way back in 1022 AD. According to a small book called The Correct Treatment of Smallpox, a Buddhist nun living in a famous mountain named Ome Shan in the southern province of Sichuan would grind up smallpox scabs and blow the powder into nostrils of healthy people. She did this after noticing that those who managed to survive smallpox never got it again, and her odd treatment worked. The procedure, called variolation, slowly evolved, and by the 1700s, doctors were taking material from sores and putting them into healthy people through 4 or 5 scratches on the arm. This worked pretty well, as inoculated people would not get reinfected, but it wasn't foolproof. Up to 3% of people would still die after being exposed to the pus. It wasn't until English physician Edward Jenner noticed something interesting about dairymaids that we got our modern solution. At age 13, while Jenner was apprenticed to a country surgeon and apothecary in Sodbury, near Bristol, he heard a dairymaid say, "I shall never have smallpox, for I have had cowpox. I shall never have an ugly pockmarked face." Cowpox is a skin disease that resembles smallpox and infects cows. Later on, as a physician, he realized that she was right. Women who got cowpox didn't develop the deadly smallpox. Smallpox and cowpox viruses are from the same family, but when a virus infects an unfamiliar host, in this case cowpox infecting a human, it is less virulent. So Jenner decided to test whether the cowpox virus could be used to protect against smallpox. In May 1796, Jenner found a young dairymaid, Sarah Nelms, who had fresh cowpox lesions on her hand and arm, caught from the udders of a cow named Blossom. Using matter from her pustules, he inoculated James Phipps, the 8-year-old son of his gardener. After a few days of fever and discomfort, the boy seemed to recover. 2 months later, Jenner inoculated the boy again, this time with matter from a fresh smallpox lesion. No disease developed, and Jenner concluded that protection was complete. His plan had worked. Jenner later used the cowpox virus in several other people and challenged them repeatedly with smallpox, proving that they were immune to the disease. With this procedure, Jenner invented the smallpox vaccination. Unlike variolation, which used actual smallpox virus to try to protect people, vaccination used the far less dangerous cowpox virus. The medical establishment, cautious then as now, deliberated at length over his findings before accepting them. But eventually, vaccination was gradually accepted, and variolation became prohibited in England in 1840. After large vaccination campaigns throughout the 19th and 20th centuries, the World Health Organization certified smallpox's eradication in 1979. Jenner is forever remembered as the father of immunology. But let's not forget the dairymaid Sarah Nelms, Blossom the cow, and James Phipps, all heroes in this great adventure of vaccination, who helped eradicate smallpox.
Okay, so hopefully I can go to the next slide smoothly. Nope, there we go. So the eradication of smallpox is one of the greatest successes of modern medicine. So I hope you all enjoyed that video. It mentioned that Edward Jenner is the father of immunology, and to really understand how vaccines work, we need to know how our immune system works. We touched upon this very briefly earlier, but I'll go into more detail now. The first thing you need to know is that immunology is all about attack and defense. Infection is a battle for survival, and germs create toxins and capsules to protect themselves and use adhesins to help them enter our bodies. We have our own protections, such as our skin barrier and mucous membranes that trap germs before they enter our body, the cilia in our throats that works to eject the particles that we breathe in before they reach our lungs, and tears, which eject the particles that fall into our eyes. We also have antibacterial and antiviral chemicals in our own saliva, while our stomach acid is so strong that it kills pretty much every germ that it can encounter. But finally, the natural defense that many people forget about is our normal flora. This refers to the population of harmless bacteria that live all over our skin and inside our gut. So we are constantly covered by bacteria. We have a lot of bacteria inside us, but they're good for us. They don't make us sick, And they help to protect us from harmful bacteria because they see outside bacteria as invaders trying to take over their space. So this competition helps to protect us as well. It's important to remember that not all germs are bad, and that the absence of bacteria can make us sick as well. As I mentioned earlier, despite having all these barriers and all these physical or first-line defenses, germs can still enter our bodies from time to time. And this is where our innate, also known as non-specific immunity, comes into play. You may know that your white blood cells are always around to help protect you from disease, but there are several types, and what they basically do is roam around looking for intruders to eat and to destroy. Macrophages and dendritic cells are particularly important because not only do they hunt down and destroy intruders, they also sound the alarm to call in the special forces, the big guns, also known as the adaptive or specific immune system. The adaptive immune system will only target whatever the innate system tells it to. So this means it's a lot faster and a lot more aggressive. You can kind of imagine your innate immune system as a bank security guard watching over the door. But when a big band of armed robbers comes through, the guard will call in the police. And the police will come and they'll hunt down every single robber. Without the guard, the police would not know that there was a problem at the bank. And without the police, the guard would not be able to deal with the problem. So that's how your adaptive and your innate immune system work together. There's one kind of always around for surveillance, and then there's one who will get called in once there is a big problem. This is the innate immune cells are here. They're very cute. And what they are is your CD4 T cells. They're the first type. They're a type of helper cell. And what they do is they run around and they secrete chemicals that activate and power up all the other cells. So they help to augment the abilities of all the others. Your CD8 T cells are known as killer T cells. And what they do is they go around and they kill any of your cells that are infected with germs before the germs can take over and then spread to the other cells. And so that's an important role as well. Your B cells are basically factories that make lots of antibodies, and these antibodies swim around in your blood and they target any germs that come in specifically. And the most important one in the context of vaccination is your memory cells. There are memory T cells and memory B cells as well. These are watchmen. They survive for a very long time. They remember what happened, and when they see the threat again, they will respond really quickly. And that is the whole core of vaccination. You can see in this graph, if you have an initial exposure, it takes time. It takes time for your body and your immune cells to talk to each other and figure out what to do and then mount a response, which you can see here in this small curve. So that is their primary immune response. So it's a bit slow, but it means that, now that they've done it, they can respond a lot quicker. So if you get a second exposure, you can see that the response is really strong, very powerful, very fast. And you probably wouldn't even notice that you'd been infected a second time because your body would deal with it for you. And that's why, you very rarely would catch a cold, for example, twice in the same season. With your vaccination, it's pretty much like a fire drill for your body, because you don't really want to be training your body to recognize diseases by getting sick all the time. That would be like trying to learn self-defense by getting beaten up. So it's not the ideal solution. Your vaccination is kind of like a safe, a harmless way for your body to get put on alert, okay, and to learn what looks dangerous and then be able to respond to it, kind of like putting wanted posters around everywhere for your immune cells and, making sure that any of the germs that come through get picked up right away. Edward Jenner used mild cowpox to develop immunity to smallpox, but modern vaccines are even gentler on our bodies now, and adverse reactions are becoming more and more rare, which is fantastic. The germs that are used to make vaccines are always weakened so that the risk of reactions are lowered as much as we possibly can. Sometimes they're treated with radiation to destroy the genetic material to make sure they don't replicate inside our bodies. Sometimes they're killed completely with heat, for example, so that it's just the dead germ that we use to inject into ourselves. And sometimes they're genetically modified. There's lots of ways you can do that. You can remove part of their genetic material. You can take them and mix them with a different vector or a different carrier. You can take parts of them and put them into something else that's harmless. Sometimes the whole germ isn't used at all, and we just take the proteins from it, like the outside proteins of a virus, for example, which is the part that our body looks at and sees when a virus infects us, or just a piece of the DNA, you know, with nothing else. The process of vaccine discovery always begins with the original germ, and then all these modifications are made to it until it can no longer cause disease. And the process of testing is pretty similar to what Edward Jenner did, but not with humans. You'd be glad to know that we start in mice, for example, first. To finish up, I'd like to just reiterate how lucky we are to have access to all of this knowledge and the healthcare systems that took so long to build. It's been a very long journey, as we can see here, from the 1900s onwards, but there's still a lot of work to do. We are still very vulnerable to pandemics. Okay, it's not just the influenza pandemic of, you know, back in 1920. We're dealing with our own current one today. So it needs, you know, a lot of people with fresh ideas and fresh perspectives to kind of join in and take us into the future. So that's all I have for today, and thank you for your attention.
All right, thank you for that. That was really cool. I went a lot.
Oh,
So we do have a couple of questions now. First question, what would be the difference between COVID and tuberculosis?
Okay, so COVID is a virus and they're very different. The scale of size is one thing already. Viruses are tiny. They can infect bacteria themselves, and then bacteria will infect our human cells. So our human cells will be about this big, bacteria about here, and viruses will be very small. Viruses are very simple. They do not have as much machinery inside them as bacteria do, which means that it's very hard to target them because it's not a lot of entry points. When you want to kill a virus, the main thing you have to do is block it from replicating. So stop it from taking its RNA, copying it, and then producing more virus particles. Because what a virus does is once it enters your cell, it hijacks it, just like a computer virus will hijack your computer. And it will force the cell to make tons and tons of copies of itself until your cell is so bloated and full of virus particles, it'll explode, all the viruses come out, and they'll infect all of the neighboring cells around. And tuberculosis is a bacteria. It's a lot slower than a virus. It will replicate quite slowly, and it creates kind of like a nest for itself inside your lungs. These are called granulomas. They're not good for you. They mess up your breathing and your lung function, and they can kind of sit in this nest forever until you do treat them, pretty much.
All right. We do have one more question. Second question, what advice do you have to young people interested in studying epidemiology?
Epidemiology, okay. Definitely programming. If you can get into programming, that would be a real advantage because it's one of the key skills I think that people don't realize are very useful in that particular field. So practicing that is fantastic. There's a lot more maths than I would be happy performing, but it's doable if you enjoy it. Pretty much take biology. You have to take your math subjects and choose any of the sciences at University of Sydney or whatever university, because I'm pretty sure nowadays you can just take a science degree and then choose your subjects, and that becomes a major. Back when I did it, there were specialized degrees, so you kind of had to choose from the outset what you were planning to do. And then from there, shop around for a good, honest supervisor. I think a lot of students don't realize that they have a lot of power when it comes to choosing their supervisor. They think that, the supervisor has to like me, I have to do really well, I have to work really hard. But you also need to ask yourself what your supervisor can do for you. because they're always interested in bringing in new people. So take your time, look for a project that you're interested in, look for a supervisor you think you'll work well with. That's super important.
And I think that's one more question from a first mentor. Do you have any recommendations on how to get pretty real world in a similar way to how we let the kids build robots?
Sorry, one more time.
So from a first mentor, do you have any recommendations on how to get pretty real world in a similar way how we let kids build robots?
So I'm guessing it's about practicing science skills in the real world before you enter a lab. Honestly, you know what? These days, ever since the syllabus in Australia has changed, you're getting a lot more opportunities to do projects in high school, but there are also workshops. So our research organization, CSIRO, they host a lot of things for kids. You sign up, you come along. I'm sure that, in other countries, the same thing is there too. But I think the main thing is practicing the way of thinking, which is all about inquiry. So you have a question, what's the hypothesis? What are you aiming to do? Good record keeping, for example. Even just observational studies can teach you a lot. So a lot of ecological studies are quite simple. You just go out and you say, okay, here's a question. How many, are sparrows, for example, declining in suburban households? And then you can pretty much go out and answer that in a week or two with continuous observation. I think those would be my main things.
All right, I think that's all the questions we have. Oh, one more actually.
Mm-hmm.
How did you get started in epidemiology?
So I did a science-based degree, but it was in genetics to begin with. And after that, I became interested in infectious diseases. So I looked for whoever, like any researcher around who was doing tuberculosis research. I went and I spoke to them and I saw what they had available and also who was willing to take me. And that's how it begins. I think your real research career does not really start until postgraduate. Most of your undergraduate degree is pretty much learning the basics, getting that groundwork so that you know what questions to ask and you know what you don't know as well. But your postgraduate is where it actually starts and you start directing a project on your own.
All right, thank you so much for this. Thank you so much for your time. This was amazing.
Thank you.
Yeah, I think that's about it. Do you have any questions right now?
No, I hope everything goes well for the rest of the day.
Yeah, thank you. Yeah. Bye.
Bye.